Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is a really heartwarming and probably my most rewarding procedure I've ever performed. And it involves this lovely patient. She's 94 years of age. She's completely blind and she's wheelchair bound. And as you can see, both, well, this is her left ear, but her right ear is just as blocked. She's got fully occluding and impacted earwax. She has hearing aids, but she can't put them in because, as you can see, they're not going to fit inside with all this wax. And even if she was able to fit them, they're just going to whistle. You're going to experience what we call acoustic feedback. All the amplified sound is going to hit the wax and reflect back out of the ear, re-enter the hearing aid microphone, and the hearing aid will re-amplify a sound that it's already amplified, and that vicious cycle will continue and you'll experience acoustic feedback. They had seen a colleague of mine, actually, a very competent colleague of mine initially, and they just weren't, let alone remove the wax. They were really struggling to get access into the ear. They use a different technique. They use a specular, a bit like the wax scope, but they weren't even able to fit the specular in the ear. Now, initially, when I first introduced endoscopic earwax removal in the UK, you can imagine the status quo. They were not happy. They were trying to criticise it. Although ENT surgeons perform endoscopic surgery, ear surgery, you have some questionable people who I don't want to say too much because it's a resolved matter now, but people who I don't feel should be writing certain guidelines, or at least lack the experience, and particularly with an endoscope, they've never even held an endoscope, and they were bad-mouthing the use of an endoscope, saying you can't use it in narrow ears, there's not enough space, and in the end, me and my colleague, Mr Rajali, ENT surgeon, and we call ENT surgeons in the UK a Mr. And in America it's Doctor, and that's why a lot of people call me Doctor, and I say Mr on purpose because I don't want to be labelled Doctor, because I'm not a doctor in that sense. I'm not a medical doctor, and a lot of the people who watch the YouTube channel are from America. So I hope that kind of explains why I refer myself specifically not as a Mr to avoid being called a doctor, but in the UK, a Mr actually refers to a surgeon, a consultant surgeon. And we had a meeting and we had these guidelines revoked because they were completely misleading and there was conflict of interest between the authors and why they wrote this. But anyway, that's back in 2017, so don't want to dwell on that too much. But there was this misconception that endoscopic earwax removal is not suitable for narrow ears. In fact, I prefer endoscopic earwax removal for narrow ears than the wax scope. It has unrivaled advantages when performing in a narrow ear because you're able to use the endoscope as a crowbar. You're able to, if you're skilled enough to do it. The problem is not everyone is able to use an endoscope, hence why I've developed the wax scope. In any case, going back to this particular patient, so they saw my colleague, they were not able to perform the procedure. And what was really heartbreaking is this patient's completely blind and they were not able to hear. So they had no mode of communication with their daughter, anyone really, but their daughter attended today with the patient's son-in-law. And it was hard to kind of experience that where you can really empathise with this individual. You can put yourself in their shoes. Not being able to see is one thing, not being able to hear is another, and you combine the two. It must be a very isolating world. And this was a very, very difficult procedure, guys. Honestly, if anyone leaves any ridiculous comments, you literally just have not got a clue how difficult this was to perform. Gaining access in the ear, removing the wax, the consistency, we're getting the canal was kept getting collapsed as we're entering. So I'm stretching this ear with these, first of all using my instrument hand to open up the ear because it's completely collapsed. The entrance is collapsed, and not only was it collapsed, it was very narrow as well, the remainder of the ear canal. And I'm using the endoscope to stretch the ear, and simultaneously I'm inserting the instrument in. And when we insert the instrument into the ear, we've got to be careful that we don't bump into the side canal walls because that will be uncomfortable. So it's a very dexterous procedure when you use an endoscope. Well, any mode of earwax removal is, but particularly so with an endoscope. So we're past the second bend, and I've had to put some oil in, and this is another challenge. When you've got a really narrow ear, I try and avoid using oil because it collects quite easily, and no matter how much you try and dry these hairs here that are coated with the oil, it still can get blocked. And as soon as you put oil in and you perform suction, you do get more collapsing of the canal. It's just something that happens when you have any fluid in the ear and you suction it. It causes the canal walls to buckle inward. So remember, this patient's 94, so the cartilage is very weakened, particularly, and the outer third is the cartilaginous portion. So again, it just got smeared a bit here, and I'm just trying to look for a better view. So I've just gone a bit further with the endoscope, but you can't go in too far because then the endoscope's going to be touching the bony part of the ear canal, and then there will be a bit of an issue with the endoscope and the instrument. They can cross over. And bless the patient, they were so still. On the right side, so if you do stay tuned, because the right side's just as complex, if probably not more complex, they were experiencing the gag reflex. And you'll be able to visualize that, because whenever they were about to cough, I had one eye on the patient, so I quickly removed the instruments from the ear, and I had the endoscope still viewing the external part of the ear, and you can actually see the patient cough. You can see the movement of the ear, of the outside part of the ear when they were coughing, so do stay tuned for that. And the reason for the gag reflex is on the posterior canal wall, so the back section of the ear canal. So this is the patient's left, it's on the right hand side wall. You have a branch of the vagus nerve called the Arnold's nerve. And when that nerve is stimulated, so it can be stimulated in two ways. It can be stimulated physically, so with the compression of the wax against the back canal wall, or when you're peeling away the wax from the back canal wall. Or it can sometimes be stimulated just by thoughts. So some patients who may have fear of needles or blood, or are very anxious about earwax, this nerve gets stimulated. And when it does, there's a number of potential symptoms you can develop. The most common one is the gag reflex. Another one is called auditory syncope, and that's when the blood vessels dilate and the heart rate reduces, which the overall net effect is that there's less blood going to the brain, and patients can faint. And it's probably happened to me in my career 3 or 4 times. Another thing that can happen is patients can feel violently sick, and I've had that happen once, literally. And this is before we were even doing the procedure. I was just looking into the ear, so it's just at the entrance, and they said they feel really sick, and they weren't going to make it to the toilet, so we just had to open the clinic window. Luckily, the clinic chair that we performed the procedure in is nearby. I've got a kind of a bucket type thing in the clinic room, but there's no way I was going to get that in time to the patient. But now I do keep something behind the chair. It was a good learning curve, so just in case it occurs again. So it can make you feel really violently sick. And for this patient, it was just a thought. They say when they have vaccinations, blood taken, it can trigger this reaction. And another potential issue that can occur is that when you stimulate this, the vagus nerve, the branch of the vagus nerve called the Arnold's nerve, it can also stimulate, I think it's the 5th cranial nerve, which is connected to the tear duct in your eyes. So it can induce kind of tears coming from your eyes, and it can make your eyes a bit tingly. Now, I get that myself, but when we train our clear wax specialist and we practice on each other's ears, obviously I volunteer my ear if we're short, so I have full faith in my specialist when they are trained by us. And for me, it does trigger this. I don't get any tears coming from my eyes, but I do get this tingly sensation. So on the right side, you would experience this gag reflex. You'll see the patient. So we're probably on the last third now, and I can't really use any other instruments. I can't use an ear hook. The wax is too soft. Of course, can't use forceps, although I'm sure some are going to be saying, oh, why don't you use the forceps? Because the wax is too soft. The Jobson horn, it's just too deep, and it's going to be very difficult to get the Jobson horn. I think the patient just had a gag reflex there actually on this side as well. You just maybe have seen that. And when it's this deep, when you use a correct or a Jobson horn, you're going to have to go in and behind the wax up against the canal wall, so it'll be uncomfortable because it's the bony part of the ear, and you're going to have to go behind, and we don't know where the eardrum is, so it's going to be very, very difficult to remove this wax with anything else than suction. I've put oil in a few times. Now you can just start to see the eardrum at about 4 o'clock on the screen. You can see that blue tinge. So at this stage, the patient can hear a lot better. But this remaining bit of wax, it's this chewing gum consistency. You may have heard me refer to this chewing gum consistency of wax a few times, and it's really, really difficult. And because the instrument, I'm having to stretch literally the outer third out, so the side canal walls are touching the side of the endoscope here. And what I'm doing here, this is the top part of the ear canal. So when I go in with the endoscope, imagine the ear's right in front of me. Initially, I have to insert the endoscope about an angle of, if you do it in terms of clocks, about 2 o'clock. I go in, or 1 o'clock, 2 o'clock, I go into the ear canal. About a centimetre in, I have to stop. And then I have to rotate that endoscope from 2 o'clock, probably back to about 11 or 10 o'clock. And we do that, obviously, anti-clockwise. So that's the orientation. I'm having to go into the ear with the endoscope. And then when I'm rotating it back to 11 o'clock to visualize this part of the ear, because obviously the ears are bendy, I'm having to make sure the right-hand side of the endoscope is still up against the right side of the canal to stretch it open. If I don't, then the ear canal is going to close and I won't be able to get the instrument in. So once I've got the instrument, the endoscope into the ear, I've then got to put the instrument in. Now, obviously it's not a straight tube, so I can't just put the instrument into the ear. What I have to do is, similarly with the endoscope, I'm having to go into the ear with the instrument. So the endoscope is in the ear already, so I've got to keep that hand locked. So my left hand, I've got to completely lock that hand so it's fixed, it's not going to move. And momentarily, I have to then move my eyes away from the screen and look at the ear with my naked eye. I use the side of the Zollner suction probe, so the metal tube you're seeing on screen, the tip. I push the cartilage that I'm also pushing with the endoscope away further to the right with the instrument to reveal the end of the endoscope tip. At that stage, you're not seeing the end of the endoscope tip because the endoscope's in the ear, and the cartilage that you're pushing away to the right to stretch the ear, it kind of hangs over the tip of the endoscope. So we don't want to go in blindly with this instrument, because if I just poke it in the ear and trying to force it through, you're going to be bumping the side of the ear canal wall. So the proper technique is to use the side of the instrument, push the cartilage out of the way that's sitting on top of the endoscope, reveal the tip of the endoscope, because you'll be able to see that with the naked eye. If you don't put it too far, and you can't go too far in with the endoscope initially, because if you're going too far, you're not going to see the tip of the endoscope. And then slowly, you then glide the suction probe over the tip of the endoscope. You almost clip it. So the bottom of this suction probe that you're seeing clips the top of the tip of the endoscope. And that means you're into the ear completely and utterly safely. Even if it's a bendy, twisty ear, you've got that endoscope into the ear without touching any of the side ear canal walls. So the patient's not going to feel it. And then once you've got the instrument in front of the endoscope, then you can go forwards towards the eardrum, and you're not going to get any crossover with your hands. So when I first started performing endoscopic earwax removal, these are the cases that I would find really, really challenging. Because I'm right-handed, I would find the left ear much more difficult because it's a bit more of a difficult technique, stretching and dilating the ear. And then getting around that bend would be very, very difficult. And if you go around the bend in any other way, your hands are going to cross over, which means your endoscope is limited. You can't put the endoscope any further in the ear because the instrument's in the way, which then means very deep wax. You just haven't got the view with the endoscope, and then you're having to go forwards with the instrument, trying to guess how deep the wax is, and the eardrum's so far in the distance, and you're trying to remove wax which is far, far away from you visually, and you lose that depth perception. So with the left ear, if the wax is near the entrance of the ear canal or the outer third or thereabouts, you can actually lead with the instrument. You can go in with the instrument into the ear first and follow with the endoscope. But as soon as you get past that second bend, that technique's not going to work. So any of my earwax trainees, specialists, I religiously go through this technique, and obviously it's easier to show. I'm describing it, and I'm describing it for a reason, because there's a few earwax specialists just recently, after watching some of my videos, just asked me to kind of remind them how to do some of the procedures, because they were finding it difficult getting access in the manner that I was. There is a shortcut that I show the specialist. We can get the patient to help and pull their ear back, which kind of straightens the ear a bit, so it makes it a bit easier. But some patients are not able to do that. And ideally, if you're the clinician, you want to be able to do all this yourself, not relying on patients to do that, or their loved ones, because they may not come with anyone. So it's a very important technique to develop, and initially I found that difficult myself. I used to lead with the instrument, follow with the endoscope, and if the wax was on the outer third, it's not a problem, but if it was any deeper, especially around the bend here where I am now, on the anterior canal wall, I just wasn't able to gain access. So the endoscope was trapped just very laterally in the ear. I was having to just go forwards with the instrument, and you kind of then lose depth perception. So even here, I'm stretching the endoscope's in the ear first, I'm stretching the ear to the right, then can you see how the instrument comes over the top? And when it goes over the top, you know you're not going to bump into either the side canal walls. So yeah, I just wanted to explain that from a technical perspective, because I think sometimes when you watch the video, it just looks and I don't blame anyone, because you're seeing a video and it may look very easy. It just looks like a cylindrical tube, and you're going in with a vacuum. And I think a lot of patients actually suspect that's how it is as well, and sometimes they kind of wonder, well, why are you so long in my ear? Do you know what you're doing? They don't say it, but you can kind of sense it. And then what I actually do, I pause the video and I play it back to them, and I show them the challenges and how difficult it is. And that's what's great about being able to record the procedures and then talk back to the patient. You can show them what you're doing. I did have a patient today, and they were finding it slightly uncomfortable, and when I played it back, I explained that, because they thought that, oh, am I touching the ear canal wall or the eardrum? And when the patient watched it back, they realised I wasn't. It was just the wax plug. As I was manoeuvring it out, it was really rough around the edges, like sandpaper, and it was rubbing against the side of the ear canal wall. And they were really reassured then. So it's a good tool to be able to record the procedures and play it back to your patients. So we managed to get that off. That last bit that was on the anterior. Sorry, so I kind of went off a bit there, and I didn't really talk about the video in depth, but you're seeing what I was doing. So sometimes you can see it was just lodged in that anterior recess, the front part of the eardrum, and I was just trying to remove it, and it was very sticky, like glue and like chewing gum, and we just had to persevere. Now, whilst I've got this patient here, bless her, I just wanted to get as much out as I can. Now, this is not going to improve her hearing, but I've got the technique. I'm in the ear. She's comfortable, and obviously she's 94, and I just want to remove as much. I want this to last as long as, even if it's an extra month or two, it just be worth it. So after this procedure, still got the right side, guys, but she was very emotional and just kept thanking me, and her daughter and son-in-law both welled up because they could finally have some sort of communication. I think it's been a month or two. They have been referred to ENT by their GP to have the wax removed, but you're looking 12 to 18 months, guys. So, and this is not a procedure that you could perform with irrigation. It just you wouldn't get the nozzle in. It's just too narrow, bendy, twisting ear canal, and you're going to, the patient's 94, she's probably got a weakened immune system, you're flushing water in the ear, it can quite easily lead to an infection. They wear a hearing aid as well. In fact, one of the risk factors, one of the contraindications of performing irrigation is with patients who are immunocompromised, or they have diabetes, or even the elderly, because water can introduce pathogenic bacteria in the ear. And obviously I've talked about water before. Bacteria love it. It creates a perfect medium for reproducing, same as fungi. It can macerate the skin. It can leach away the natural oil layer and oily sweat layer we have, which protects the underlying skin. So even if there was a case that I think, fine, use irrigation if you must, not with this patient. It's just not the correct patient. So this is when the patient experienced the gag reflex. Now, purpose is just left the endoscope outside the ear, just wiping the lens. I forgot to edit that bit out. So again, now with the right ear, the technique, now I'll come back to the technique in a moment, but because this patient has already knows she's got a really bad gag reflex here, as I'm removing the wax, I'm always ready to come away, and you're going to see that a few times. I think it's going to happen in a minute. You can probably you can actually predict it, because you can see the patient moving initially before they went on the full cough offensive, and when they were really, obviously when they're coughing quite badly, you've got to come out of the ear, because especially in a very narrow ear, if the ear is quite wide and big, then you might be okay, but any movement of the head here, it's going to hit the instrument. I can just feel it again in a moment. There we are. Just gone back in. So if you're right-handed and you're performing endoscopic earwax removal, the technique is slightly easier. Because of the angle of the instrument, you're coming from your right side downwards. So I'm going with the endoscope here. I'll just describe it in words. Just past the first bend, to the part of the ear canal at the entrance on the left-hand side where you see all the hairs protruding. That's the first bend. I try and just go slightly further past those hairs, and then I'm using the left-hand side of the endoscope, and I'm stretching the ear to the left. Now, another important bit that I didn't mention on the left side, but I'll kind of mention it here. You have to make advantage of the anatomy of the ear. So the ear is an oval shape. So there's more space upwards and downwards than there is left to right. So you have to have the endoscope. So in this right ear, I'll position the endoscope in the ear around 7 o'clock, which then gives me the rest of the ear canal to use the instrument to go over the top. If I position the endoscope in the middle of the ear, for example, well, how are you going to get the instrument in? Because that endoscope being in the centre of the ear canal is limiting space all the way around it. If I have the endoscope at 9 o'clock, well, then you can't take advantage of the height of the ear canal, because the instrument's going to have to go side by side. It's going to have to go in at 3 o'clock. And then you're fighting for space. Of course, if you have the endoscope at 12 o'clock, practically you're not going to be able to put the instrument in lower. The instrument has to go over the top. So for that reason, you want to maximize space for the instrument. So in the right ear, you put the endoscope in initially when you insert the instrument. You position it, I would say about 7 o'clock, 7, 8 o'clock. In the left ear, it's around 4 or 5 o'clock. And so I'm stretching it to the left at 7 o'clock, which means I've then got 7 o'clock. If I go clockwise, all the way around back to 6 o'clock, I've got all that space, because we're using the anatomy of the ear, the oval geometry of the ear. And then with the right ear, when you stretch the ear to the left using the endoscope, it's a lot easier to insert the instrument over the top of the tip of the endoscope. So with every time I enter the ear, doesn't matter if it's the left or right ear, the first key, you break down the technique. So technique, the first step is to stretch the ear with the endoscope. Step 2 is to lock that hand. You have to make sure that hand is locked, it's stable. And you've got to obviously make sure it's in the right position to the bottom, as I said, quadrants. Step 3 is you've got to get the instrument over the endoscope. You don't want to go side by side if avoidable, especially in a narrow ear, because you can quite easily clip the side ear canal wall if you do. So if you go over the instrument, it means the instrument enters the ear far away from the side ear canal wall, so it's completely, patients don't notice it, they don't feel you going in with the instrument. And then once you've got the instrument in view, then you can go forwards towards the wax, then you can go around bends. So again, I've stretched the ear, I've gone over the top of the endoscope with the instrument, and once it's in the ear, obviously you can go forwards. Now, when you're doing it so many times, it just looks like one fluid motion, and that's because it is. But when you're training, when I train specialists, we break it down. So, and I can be quite a tough trainer. There are people who've experienced tough, and it's all for the benefit of the specialist. But I do put them through their paces, bless them. And it's just because it is technique driven. Once you've got the technique and you keep repeating it, you get that muscle memory, and then it becomes natural, it becomes an automated process. I know a lot of people who come on the course, they probably, I always joke with them when they come on the course, I bet when you go home, you're going to hear me say 4 o'clock, 7 o'clock, stretch the cartilage, lock your hand. These are the phrases that I use. And when we're training them, I just go around watching them, because we start off on dummy ears, so I can watch them before we go on to real ears, and I'm just over the shoulder and just one by one say, look, do this, do that. And it's great, I think, because that's the only way you're going to learn. You have to be told. And that's when people buy an endoscope. There's people that buy endoscopes, audiologists, doctors, nurses. They've never held an endoscope. And I say to them, you can buy it if you want, but you're not going to get your money back, and you're not going to be able to use it without the training. Simple as that. I think they just think they think it's easy, and I can kind of understand when you're watching a video, everything looks easy. But I think when they come on the course, they realise, wow, okay, we get it now. We get why we need the training. There's no way on earth to be able to do this without the training. So I've talked a lot about the technique today, and the reason for that, our Clearwax training course is coming back very shortly. I paused it for the last, I think it's coming up to 2 years now, and that's because I just found that the endoscope is too difficult to teach a lot of specialists. It is a very difficult skill, and I understand that it is very difficult, and not everyone can do it, and it's through no fault of their own. So then that's why I've developed the wax scope, which is for me the next best alternative. So training is on my mind. I'm developing new training material, and one of the things I'm doing is talking about the technique. It's always good to be able to obviously physically show someone how to do the technique, but complement that with describing it as well. And when you get both together, it really, really hammers the message home why you do. Because I think also with the technique, it's all good and well me saying when I train specialists, this is how you should be doing it. But I think they need to also realise why I'm asking them to do it. So like I've explained, if you just put the endoscope in the middle of the ear and put the instrument in and hope for the best, well, the ear canal's not straight, you're going to bump into the canal wall. Even if you do manage to get it in, you're going to, after grazing the patient's ear, making them bleed, there's going to be no space to manoeuvre the instrument because the endoscope's right in the centre and it's taking up all the space. Whenever you manoeuvre the instrument, it's going to touch the tip of the endoscope and it's going to obstruct it. So this is the last section. As you can see, I'm trying to break this away. It's lodged in the inferior recess, you can see, and when I get this plug out eventually, you're going to see why it was so difficult to remove. The umbo region, the centre part of the eardrum, there was a thick layer of skin, so hyperkeratosis, you call it, where there's a lot of thickened skin at the centre of the eardrum. And in fact, that region of the eardrum, the umbo, is the site of where all the outer ear, the epidermis layer skin originates from. So it all stems from the centre of the eardrum, and then it migrates sideways to line the ear canal. And this was attached to the centre of the eardrum. It was really, really difficult. Again, it was like a chewing gum consistency. So whilst you watch the rest of this, I'll just explain some of the patient's reactions afterwards. So after we removed this, they just paused for a couple of minutes, and they were very teary, and so were their family, and they were very, very grateful, as you can imagine. And I think they came in thinking that maybe I wasn't going to be able to help because it was a difficult case and it wasn't easy. And then the patient spoke with their family, and it's the first time they probably communicated in, as I said, months. The patient then joked, says, well, she doesn't need the hearing aids anymore. She still did need the hearing aids. It was quite obvious if she had an underlying hearing loss, but she was able to communicate with in the absence of the hearing aid, actually. And then we put the right hearing aid in. She hasn't got a left one at the moment. And then she kind of went a bit teary and emotional again because she then noticed the difference with the hearing aid. And then after that, the patient just kept saying thank you. She could not stop. And also their family. And obviously we charge an additional fee for the second ear. And when the patient's daughter went to pay it, and she said, is that it? Is that all I owe you for the second ear? You've just literally given my mum a new lease of life. Surely, you've got to charge more. And so no, these are our fees. They're set fees. we were there for a long time. You can see the procedure here, it's 33 minutes now. I've edited the bits when I'm out of the ear, so I think the patient in total were here for about 45 minutes, if not longer. Now our appointment slots are 30 minutes, so yeah, we did go over, but whenever I go over, it's going to be a complicated procedure, and I always go out to speak to the next patient who's waiting, just to explain, just got a bit of a complex case, it's going to take a bit longer, we're running a bit behind. Everyone's fine, because I think the next patient realises if it was them who's got a complicated case, well, they want me to take, try my best for them as well, and to do it properly and not to rush. There's some cases when I have got with patients where it's such a complicated case, and I know it's going to take a lot longer, and I don't want to keep my next patient waiting as long as they would have to, because it's not obviously fair on them. If it's I think up to 15 minutes, I think it's fine. But very occasionally, I know I'm going to need longer. So I just asked that patient who I'm treating, look, we're going to pause at the moment. I've just got some patients. I don't want to keep them waiting any longer than I have. And then I can get this patient, because do you mind coming back at the lunch break, or just waiting in the waiting area? And then if I do finish early, because sometimes the procedures are quite very quick, straightforward, and I can catch up time that way. And again, patients are fine with that. So it doesn't happen regularly, but probably once or twice every 2 or 3 months, if I'm honest. And then where I'm situated, there is like a cafe, there's little shops there, a farm shop, so some patients can just go for a walk and come back, and we can actually get their number and ring them if we finish a bit early and we've got gaps to come back. But we try and accommodate. So these are the procedures that, I think a lot of people have seen it recently on YouTube and other outlets, and even with my own profession, we've got, there's all these kind of forums and groups where I'm a bit of a wanted man still, for raising awareness about clinical ear care in the UK. And YouTube, in particular being YouTube, you're going to get some silly comments, and sometimes it's disheartening, because, you shouldn't really, no one should be criticising someone at their job if you don't do their job yourself. I wouldn't criticise anyone watching this YouTube video doing a specialist job that they've been trained to do, because I don't know the ins and outs, I don't know the nuances. Now this is very interesting, but you would have seen the eardrum there. Now you've got to be very, very gentle there. You could see the eardrum as I was suctioning, it was being pulled laterally towards the entrance, but I just wanted to get this thickened skin out. So this is where that plug was attached to, and this is the site of where all the epidermis layer skins in the ear canal is generated. It's the proliferation site, sorry. And the skin cells here then migrate radially away to the sides of the eardrum and then coats the ear canal. But yeah, going back to the point I was trying to make, sometimes I kind of wonder, is it worth doing? I'm not doing this for monetary gain, because you don't really get much monetary gain because of the content. The ads are limited. So do I need all the headache? Because I don't purposely go out and read the comments and try and avoid reading comments, if truth be told, but sometimes with certain apps, you go into them and they just appear, and sometimes you do read them because you feel that you should. But yeah, this makes it all worth it. It's probably the most rewarding and challenging case I've performed today. Take care, guys. Speak soon. Bye.